guys? Fantastic? Good. So my mic's coming. They gave us the wrong one, so I'm just going to have to yell for a little while. How did last week go? How was the online lecture? Work out okay? So good, you'd rather have that every week? No. That's the danger, right? You put them online and everyone's like, all right, well, yeah, I can watch the football game and listen to your lecture. So let's just do that every week. Any questions from last week before we get going? Okay. So for the grad students, thank you, Kelsey. Oh, that's better. For the grad students, I need you guys, I want to talk to you guys like after class, because I've got your exam course here, and then we need to talk about the semester term paper. Okay, so we can get started on that. And then we're going to do the hand back at the break. I'll probably release you kind of in groups so it's not such a madhouse at the break. And then obviously we'll have them afterwards. You only get the Scantrons back. If you want to see your test packet, you just need to come see me in my office. Okay? All right, so we're on nervous system disorders. And next week we actually have Dr. Miller. Oh, question?
Yeah, are you going to post the exam online?
No. Yep. You need to come into my office to see them if you want to take a look at it. And I encourage you to do that so that you can kind of figure out what did you miss? Did you do a transposition error? Did you miss a bubble? Did you get off sequence? Or did you truly make a mistake on the exam? And a lot of times it's super helpful to walk through the test packet. And it's better to do it when you're with me so that we can go back and forth on the questions. Like, I don't get this, or tell me why this one's wrong, etc.
You said that every test is cumulative. Is there going to be like exact questions for the legal test?
No. Just cumulative concepts.
Okay.
Yep. So, like for example, inflammation is something that you should never forget all semester. And it'll keep coming back with every disease. In fact, we'll see it today in nervous system disorders. We're going to see inflammation show up in some of these problems, like for example with MS, multiple sclerosis. We'll see it show up even with, at some level, with Alzheimer's, with the plaque formation, the beta amyloid plaques. And then some of you pointed out the module got flip-flopped somehow, and then I corrected it. Did you guys see that? Some of you noticed that? I tried to correct it the week before, because some of you were working like a week and a half before, which is kind of cool, because then it gives me a heads up that if there's something wrong, I can catch it and change it out. All right? So thank you for those couple of students that pointed that out to me. I tried to respond to your email. I had been out of town, so if you've emailed me since Monday, I haven't responded because I literally just got back into town about an hour ago. So we're right into nervous system disorders, and next week we actually have a guest lecturer. Next week is Dr. Michael Miller, and just a couple of rules of engagement. Kind of like a guest comes to your house. I would expect from everyone here that we would welcome him, and that you guys treat me with a tremendous amount of respect, and I really appreciate that every week. And so I would hope that for Dr. Miller, it would even be a notch above that because he's a guest essentially in our home. Okay? His only requirement that he asks before he lectures is that we've already covered the nervous system. And he is adamant that you students are experts within the nervous system. He'll probably ask you questions. So he used to teach, he's a retired medical school professor, and he's a generation above mine. And so the style is a little different. Okay? It's, I don't know, how would you characterize it, Kelsey? Abrasive, okay. In a good way, in sort of a understood way. but that generation is not okay with students having any sense of entitlement, let alone any potential. Yeah, I mean, he totally knows what he's talking about, but he's a generation above all of us, and they did it differently back then, okay? But he really knows his material, and I think it's neat to get a totally different perspective from another faculty representative from a different school, especially because he has a lot of clinical expertise in this space. And he's going to talk a lot about dementia, and he may quiz you a little bit, okay? And he's a great guy. He's actually my neighbor. I've known him for a long time. He lives in my neighborhood. He doesn't live like next door to me or anything. But he's fantastic. So I just want to make sure that you guys are prepared for a different style, from a different generation, and know your stuff. Review the nervous system. Review the anatomy. We'll ask you about different areas. And I'm going to cover real fast the review of the nervous system in the first part of this lecture, because I want to make sure that you guys at least think about what is it that I've already forgotten from 201. So if we look at the nervous system, we've got a number of different cell types, if you recall. We have neuronal cells, which send the action potential. They're the ones that are excitable cells, so they actually send the electrical signal downstream. And then we have supporting cells, and those supporting cells we call glial cells. And those glial cells exist in 4 different formats in the central nervous system, and in 2 different formats in the periphery. So in the central nervous system, we have oligodendrocytes, astrocytes, microglial cells, and ependymal cells. And then in the periphery, we only have 2 variations, and those are a smaller subset, so they're satellite cells and Schwann cells. So let's go through these. In the pictures that you see up here, in the upper right is a picture of the oligodendrocytes. And does anybody remember what the oligodendrocytes do? Let's practice next week. Who can tell me what the oligodendrocytes do? They myelinate the axon. What does that do for the axon? It insulates it, and what does that do? Physiologically. Saltatory conduction. And what does that mean? Why is that beneficial? Speed. Is fast or slower? It's faster. Okay, very good. So this is the kind of back and forth that you'll have next week, and he might just call on you. Like, well, what do you think? Like, I didn't raise my hand. I don't care. You know this, right? So that's kind of the understanding that at the university level and in medical school we typically expect. Okay? So my style is a little bit different than Dr. Miller's, but we're going to practice it today. Okay, so the upper left. The upper left is what? Those are astrocytes. Very good. And what do astrocytes do? What's that? They don't necessarily make the blood-brain barrier. Okay? The ependymal cells are responsible for that. So next week, Dr. Miller might just say, no, wrong. Which is correct, okay, right? But it's just more matter of fact. So the astrocytes, these guys are responsible for transportation of nutrients and the removal of waste products. The cells that really help to facilitate this blood-brain barrier are which ones? The ependymal cells. And which cells would those be? Those are on the lower right on this slide. And they facilitate a tight junction at the level of the ventricular system. They line it, and they help to facilitate that blood-brain barrier place, okay, along with the endothelium that is very, very tight within the vasculature of the brain. The one that we skipped are the microglia on that list in order, and that's the lower left. What do microglial cells do? Anybody? Something with repair, that's correct. What do microglial cells do? Lower left. They function like little, what? Macrophages. The microglial cells are like microphages instead of macrophages. That's how you remember that. So if you have inflammation, or if you have a stroke, or you have damage within the nervous system, you'll see a lot of microglial cells in the area because of the facilitation of trying to clean up that wound. Okay, now in the periphery we only have two types. We have one that's the counterpart to the oligodendrocyte in the central nervous system, and that is what? The Schwann cell. So it myelinates the periphery. And in the periphery, what additional benefit do we have from myelination? We have saltatory conduction, we have an increase in speed of potential. What else? What does that myelination do for us in peripheral nerves that it does not do for us in the central nerves?
Are you talking about allowing it to branch for repair?
Yes, I am. Allows it to create a regeneration tube so that when the nerve needs to repair itself in the periphery, you can regenerate to a certain extent. You do not have that capability in the CNS. That's why with stroke it's so problematic, because if you lose those nerves in the brain, you typically do not regain them. A lot of you probably had surgery somewhere, right? And they came in a peripheral location, like if it was your knee, and they sliced open your knee to repair an ACL or a meniscus, then that line of that scalpel blade probably was very, very numb or non-feeling for a long time, and then eventually it kind of, that zone of numbness kind of decreased. Now, it may never have dissipated completely, but it's probably healed over time. Okay, the Schwann cells, what do these guys, the satellite cells, what do these guys do? Who are they like, the satellite cells? No, they're most similar to the astrocyte. Okay? The astrocyte. Okay, so additional review. The synapse. I would suggest you take a look at the synapse. And so you remember that, here is our cell A, and here's our cell B. And here is a box that's blown up to the left that actually shows you how the nucleus is located in the cell body. And through axoplasmic flow, you can actually move vesicles up and down the axon. Remember that? And why would you need to manufacture stuff here near the cell body where all those ribosomes are and move them into another location? Give me an example of something you want to transport to another location in the cell. What's that? Acetylcholine. Perfect. A neurotransmitter. So then over here we see this little gap, and this box is blown up right here, and you've got these vesicles containing acetylcholine or some type of neurotransmitter that will fuse with this membrane, be released, and go across the synaptic cleft. Okay? Easy enough? Remember the difference between CNS and PNS. Central nervous system is really the brain and the spinal cord, and the peripheral nervous system is everything outside of that. And where do cranial nerves fit? Central or peripheral? Central or peripheral? Not central. Cranial nerves. They're part of the peripheral nervous system. They're not in the brain. Right? They come out of the brain. How about spinal nerves? CNS or PNS? Now I'm nervous. I don't want... This is like next week, right? PNS, why? Why is it the peripheral nervous system? Because it exits the spinal cord, so it's not contained within the spinal cord. So cranial nerves and spinal nerves are part of the peripheral nervous system. Again, all of these are reviewed from 201. I'm just trying to remind you what it is that maybe you forgot. And then you can see we can break it down into sensory versus motor. We can go from visceral to somatic. And we have, obviously, sympathetic versus parasympathetic. Now, somebody tell me, what is the difference between parasympathetic and sympathetic?
Sympathetic is fight or flight.
Okay, sympathetic is fight or flight, and you're going to tell me what parasympathetic is. Rest and digest. Okay? So fight or flight, does that ramp up heart rate or slow it down? Speeds it up. What about parasympathetic, rest and digest? What would happen to heart rate if you activate the parasympathetic nervous system? You slow down heart rate. Okay, good. Would it be a good idea to maybe take a look back at 201 notes on this? I would be saying yes, especially before next week, because Dr. Miller will go even faster and kind of drill you on what does this look like. Okay? All right, and again, now let's look at the brain. Now this is where he really dives in. This is where his area of expertise is. So I'm trying to prepare you for next week. Okay? But we also are preparing ourselves for this week's lecture. Okay, but next week's going to get a little bit more clinical. Now, one thing that will be nice for you to remember, especially if you didn't have me for 201, is that the brain itself, the central nervous system of the brain and the spinal cord, are organized from a back to front orientation. Okay? What information comes towards the back? Motor or sensory? Sensory. Where's your sensory cortex? Is it the precentral gyrus in front, or is it the postcentral gyrus in back? It's the postcentral gyrus. You remember that? You're like, I'm starting to. So you get information from the the dorsal root horns, right? From the backside of the spinal cord, and then the motor efferent pathways comes out the ventral root horns. And your motor cortex is in the front of your brain. So you get sensory input coming in the backside of the central nervous system, and motor input comes out the front. It's a great way to remember kind of where you are in the brain. So for example, if you look at Broca's area, is it towards the front or the back of the brain? It's towards the front, correct? If you're having trouble with that, you definitely need to review. Okay, because this is, what structure is this? That's the cerebellum. That goes to the back, okay? So the front, Broca's area, if you had a lesion to Broca's area, would it affect your ability to form speech or your ability to understand speech? Form, because it's in the motor part of the brain. Okay? Likewise, if you have Wernicke's area, right? And Wernicke's area is here. Is that towards the anterior or posterior portion of the brain? Posterior. So a stroke or damage or a lesion to Wernicke's would be a problem with speech formation or understanding speech? Understanding speech. Okay, a lot of people that have damage to this lobe here, this region, are going to be speaking just fine, but they don't really know what they're saying. This up front is they're having trouble. They know what they want to say. They get frustrated because they can't find the right word. It's a big difference between the backside versus the front. And Dr. Miller will organize the brain in a couple of different axes. And that's the way that his lecture will be laid out. It's a very nice strategy. But if you're not familiar with looking at the brain in this fashion, it might be a little foreign to you. Okay, and then additionally, so here's our postcentral gyrus, which is our sensory. Here's our central sulcus. And then here's our precentral gyrus, which is our motor. And you remember that the motor cortex, there's a map of the entire body on that motor cortex, and neurons that exit out of that certain location feed, say, the hand, or the face, or the lower limbs. So if we have a stroke to the motor cortex, and it's on a portion of the motor cortex that controls, let's say it's on the right side of the motor cortex, and it controls the left arm, then that stroke patient's left arm might be compromised. Okay? Well, why is it just the arm and not the leg? Well, it probably just pinpointed, fortunately, one location. And so they survived the stroke, but they have this residual challenge with motor function. Okay? Or they might have a stroke and there's a constant ringing in their ear. They might have a stroke and they can no longer see out of one eye. Okay? So you can figure out where that stroke likely targeted. And this is, of course, if they're fortunate and they survive. Because some strokes will kill a patient right away. Okay, let's look at the ventricles and the meninges. Sorry, question? Yes?
One, do lawyers or people who are good with words and speech, do they have an overdeveloped understanding?
Lawyers have an overdeveloped
People who are good
no
with
comment, I
words.
plead the fifth.
And then
So let me answer that question first off. So there's been a lot. So for example, if you look at, it's probably less about like the size of the area. It's more about the neuronal networks. So for example, a better example that I would like to use is like musicians, extremely talented musicians. So when you think about, or you think about an athlete, like an elite athlete, there is such synchrony between the brain and the rest of the body for them to be able to do those types of activities. And to do them at a level that most of us can never reach. Okay, and part of that's training, but another part of that is the way that the wiring is organized. So what does that mean, the wiring is organized? Well, we call it neuroplasticity. So the brain is organized with neurons that flow into different regions of the brain. And as you practice motions or activities, you reroute those neuronal pathways to be more efficient and to use the areas that you use on a regular basis. So to use your question or use your example of somebody who speaks on a regular basis and they're very eloquent with their speech, it's probably that neuronal circuitry has been plastically modified so that better neuronal networks come through when you're initiating an activity. The same thing that would be for a musician playing a musical piece on the piano or a guitar or both. I mean, you've seen some of these street musicians and they're playing like 4 instruments simultaneously. But how does that happen? And the other thing is, if you think about an elite athlete, someone like a pitcher or a quarterback or a dancer, a ballerina, there's a gymnast. There is an activity that's practiced again and again and again, and that neuronal circuitry becomes more efficient. It's also one of the reasons that stroke patients can recover, even though I just told you central nervous system nerves don't regenerate. They don't regenerate, but if you can find new networks or new pathways to reuse, and that's why physical therapy is so valuable, and that's why we can recuperate some of these patients post-stroke. Because the brain does have an incredible ability to kind of rewire itself, or find new networks that it's not using to get the same task accomplished. Okay, if we look at our meninges and our ventricles, if we remember, we have this ventricular system that flows cerebrospinal fluid throughout the brain. We manufacture cerebrospinal fluid throughout the day. The brain produces and absorbs about 500 mils per day. So you're constantly recirculating. Where does it come from? Where does the cerebrospinal fluid come from? Where does it come from? It comes from, so it's produced at the level of the ventricle in the choroid plexus of each ventricle. The ventricle's ventricle just means chamber, right? So the ventricle is just a chamber. It's the same word that's used for the heart, the ventricles. So these are just chambers. We've got 2 laterals, and we have a 3rd and a 4th, and they're just chambers or rooms that house fluid. Well, where's the fluid come from? Really? It's blood filtrate. Very good. Nicely done. It's blood filtrate. So you circulate your blood to the level of the choroid plexus, which is a highly vascularized structure, and then you filter with specialized endothelium, and you keep pretty much everything except for the plasma comes through. All right, so ions and mostly water. That's it. So it's a clear, colorless, odorless fluid. And there's no red blood cells because the red blood cells can't even get through. So you know that the fenestry, or the windows, that's a word that means window, the holes in the blood-brain barrier epithelium, or endothelium, excuse me, the endothelial cells are too small to allow a red blood cell to pass through. And the diameter of a red blood cell is approximately what? You should always know this. I mean, you never know when you're going to need this piece of information. What is the diameter of a red blood cell? It's not 20, that would be big. You're close though. It's about 7 to 10. Okay? So those holes, those fenestrae are smaller than that, allows for this filtrate to come through. That circulates to allow the brain to have nutrients and the removal of waste products and to protect it, right? It bathes it all the way around. It circulates, it drains from the fourth ventricle back into the bloodstream. Chemical stability, protection, as well as buoyancy. So the brain itself essentially kind of floats in this fluid. It's a very safe place for a critical organ. You've ever bobbed for apples? It's fall time, right? So you've seen apples in a bucket of water and how it just kind of floats on top. Essentially, that's kind of what the brain is doing in your cranial space. And so it's critical that you circulate that fluid because there's not as much as a basin of water. There's only about 150 to about 300 mils that are there at any one given time. And you recycle it about 500 mils per day. Now the meninges. Tell me about the meninges. This is all review, guys. But this is critical.
3 of them.
There's 3 meningeal layers. What are they?
Arachnoid, dura, and
Arachnoid, dura, and you can look at the cheat sheet up here.
the pia mater.
And the pia. Okay. So those are coverings that come over top of the brain. Now, quick review is the spinal cord as we make our way down. Again, in 201, we cover these lectures with about 3-hour-long lectures in total. So we're going through this pretty fast, but if we move our way down to the brain, now what we have is we have higher thought higher up on the brain. Right? So your frontal cortex, what belongs in the frontal cortex? What kind of things happen at the level of the frontal cortex?
That's reasoning and
Reasoning.
The newest developments
Newest developments?
of the brain. It's the most newly developed portion.
It's the most newly developed portion of the brain, I agree. What all goes on up there? Intelligence, intellect, personality, right? Okay. So you should be able to know what certain regions of the brain do, because if we had a stroke or we had a lesion in that area, then I might ask you on the exam, what would you expect the patient might struggle with? That's totally fair game. So I would review all these major centers. Now as we work our way down, we have less higher thought and we have more autonomic. So the brainstem are like automatic things that you don't have to think about. When you get a math equation, okay, or I ask you a question about where this center in the brain is located, you're using higher thought. You're using your frontal cortex. When I engage you in a question and it's uncomfortable, and you say a joke and you kind of squirt, that's your personality coming through. That's who you are. That's your frontal cortex. Things like heart rate, breathing, you don't even have to think about those. So those are automatic functions, and they function lower down on the brain level, at the level of the brainstem. So look at the pons. This takes information between the cerebrum and the cerebellum. It's associated with sleep, hearing, equilibrium, taste, eye movements, facial expressions, respiration, swallowing, bladder control, and even posture. If we look at the cerebellum, okay, this is towards the back here. This little brain, as it's referred to, has a left and right hemisphere. It's connected together by the structure known as the vermis, rather than the corpus callosum. The corpus callosum is what? What does the corpus callosum do? Right and left hemispheres of what? Of what brain? Which part? The cerebrum. Very good. Okay. Okay, so this is, review these things over the next week. For next week. We don't have gyri, we have folia here. And we don't have sulci, we actually have grooves. But we have similar architectures, what we saw in the cerebellum, or cerebrum, excuse me. This structure really functions to control muscle coordination. So a stroke here would cause, postural problems, or even tremor or shaking, difficulty walking, difficulty writing. Now, those kinds of things can happen in the cerebrum as well. But the muscle coordination of numerous activities in synchrony is really what the cerebellum does. It has a large component of the neurons in the brain, and it's a very small structure. It's less than 10% by volume, but it has over 50% of all the neurons that we find. All right, if we look on the cerebellum, it sits above the fourth ventricle. The white matter we call is arbor vitae on a mid-sagittal section, or any sagittal section. Mid-sagittal is the most obvious. This word translate, or this two words translate to tree of life. If we move further down, so now we were here, now we're here. Further down on the stem, we're at the level of the medulla oblongata. Autonomic functions like cardiac centers, adjusting the rate of the heartbeat, and even contractility of the heart, or how forcefully it beats. That was all 202 stuff. We have reflex centers here for coughing, sneezing, gagging, swallowing, vomiting, salivation, sweating, movements of tongue and head, and general arousal. In capital punishment times when it was a little bit more of a gruesome way to do it, death by hanging, this is where they would try to have the noose snap the brainstem, because it was supposedly, if it's done correctly, it would be a very quick and painless death. Okay, because the patient's heart would stop immediately and they'd stop breathing. It also tends to be the location today that snipers are trained to actually sharpshoot and take out a target. Okay, so they target kind of at the base of the skull from the back, or right through the throat here, but a little bit high, so the bullet comes through and it kills the target immediately. All right, so if we finish up with our review, take a peek at the overall pattern of the sympathetic nervous system and the parasympathetic nervous system. Look to see the different target organs that they innervate. See if you can remember maybe examples of each. Like, for example, how the vagus nerve. Does anybody remember what the vagus nerve does?
Controls blood pressure. That's blood pressure.
That's blood pressure. Yes?
Slow down.
It does slow down the heart, but that's not the only organ that it innervates. If you look at the vagus nerve, when you're reviewing, it's going to be on the parasympathetic side, and it innervates the heart here. It innervates the stomach. It innervates the intestine, the kidney, and the intestinal alimentary canal. So that one nerve does all of that. So I would take a look back at parasympathetic and sympathetic trees, see what target tissues they go to, and see if you can just conjure up a few memories of some of these specific pathways. Okay? The biggest one for next week is going to be refamiliarizing yourself with the locations of the brain, the different lobes and what they do. Because that's probably where the questions to the audience will come from is, what does this center do? What's the corpus callosum? How's the brain organized? Okay, what does the brainstem do? Where's the hypothalamus? How about the amygdala? What are they responsible for? Where's memory? Where's short-term versus long-term memory? Okay? So he'll go over that, but he'll expect that you remember those centers, so he'll probably quiz you on it, and it's just a little awkward when it's a guest lecture. You're trying to be respectful, all right? Okay, we ready for new material? Talk about some disorders? Is the review overly painful? Maybe it's been too long since you've had it. Okay, let's look at some of our acute brain disorders. I want to remind us of the ventricular system and the meninges. And so the reason, so I get students that ask me, they'll say, well, your prereqs are 201, 202, and 205. So A and P, first and second semester, and then micro. But I'm taking, I'm taking A and P right now. So will you override me in? You guys think that's a good idea? No, me neither. So I never let it happen. And I know some students think that I'm just being mean, but there is a background of information that you really need to have in order for you to be successful in this class and not just survive. And, I don't want you struggling. And probably some of you are like, yeah, I had it, and I'm going to have to go back and look at some of those lectures because it's been a little while. So here's what I'm going to do. I'm going to post in this week's section some of my 201 central nervous system lectures, and you can take a look at them. Okay? In case you haven't, you don't know where your stuff is. You can look at these old lectures from 201. Okay? So that'll be up probably by tomorrow. So if we look back at the ventricles and the meninges, remember that the role is to circulate fluid. Well, what happens when fluid doesn't circulate well? So if you get fluid not circulating well within this ventricular system or within the meningeal layers, then you see the above picture, the above right, and that's actually hydrocephalus. So that's an increase in cerebral spinal fluid, an increase in pressure, and it's usually because of one of two things. Either you have an impairment in the drainage of the cerebral spinal fluid, so you're not draining it out fast enough, or you're manufacturing too much. Okay, so these are two lateral ventricles that are completely blown out. They should look about like this one right here. You see how much smaller these guys are? Look at how big and exaggerated those are. Okay, so there's fluid that's building up in the ventricles, and it's causing an increase in cerebral spinal fluid. Now, the lower right picture is called cerebral edema. Cerebral edema is a buildup of fluid in the parenchymal tissue of the brain. So the parenchymal tissue is like the functional brain tissue. That's what that word means. So it's not the extracellular matrix. It's not the stroma. It's actually the functional brain tissue itself has too much fluid in it. And so what you're seeing here is you're seeing a shift down the midline. So if you look here, you can see that this midline is shifted because of the buildup of fluid. So the buildup of fluid, there's a midline shift to the right side, right? This is the patient's right, correct? So this is pushed over to the right side because you have too much fluid on the left. So there's two potential causes for this. Number one is cytotoxic. So cytotoxic would be an increase in fluid that's secondary to neuronal or glial cell injury, or it could be endothelial cell injury of the blood vessels of the brain circulation itself. And it's usually due to an insult from a toxin. So that's why it's considered cytotoxic. So the characteristics are swelling of the cellular elements, as shown here. Usually acute cerebral ischemia, meaning that there's low oxygenation of the tissue itself. And then the neurons and the glial cells and the endothelial cells swell and enlarge because of hypoxia. The second one is vasogenic. Vasogenic is characterized by an increase in the fluid volume due to over-leaky endothelium. So the vasculature that perfuses the brain tissue itself, those endothelial cells become too leaky and they allow too much fluid to come out. Vasogenic, like vessel vasogenic. Okay? Cytotoxic, usually it's a toxin that's causing a problem. Vasogenic, there's a problem with the blood vessel architecture. Yes?
So would a high altitude cerebral edema be a vasogenic one?
High altitude cerebral edema would be vasogenic. Yep. Assuming there's no toxin associated with it. If there's no other issues, yes. Yep. So the question at the bottom is, what happens to ischemic or hypoxic cells? You guys remember? Think back to our inflammation lecture. it becomes necrotic. The tissue moves into a necrosis process versus apoptosis. And what are some of the symptoms that we see with the tissue as a result of that? You have an increase in fluid, right? So you have swelling that takes place, right? And that's what's happening here. That's one of the first stages. So this is due to an inflammatory problem downstream from a hypoxic insult. You understand the two differences? Okay. So let's take a peek at cerebral edema in this particular picture. So this is a picture post-mortem where the skull cap was removed, and you can see how the gyri are flattened because the brain has swollen so much that it's pressed up against the cranial cap. Okay? There's a case of hydrocephalus, in contrast, that I want to talk about. This one is particularly of interest. This is in India. And the reason I bring up this example is a lot of times when we talk about this specifically in 201, a lot of students think that this hydrocephalus is a problem that doesn't exist anymore. And that's not true. In Western cultures where we have great health care, a lot of times we will treat this very quickly. Okay, but in this case of Runa, this is an 18-month-old in India. And some of these pictures are going to be a little tough to see, but I think it's important for you to see that these are real issues that happen even today. So this was a couple of years back. And her head grew to a circumference of 94 centimeters, which is about triple the size of a normal baby at 18 months of age. So it's her parents' only child. Her father's a bricklayer. He makes less than $3 a day in this little town, so they can't afford to treat. And you can see the size of her head in this picture, and this is how big it got. And her eyes are actually open in this image. You can't really tell. Hang on. Let me turn this back off. So her eye, you can't really tell that her eyes are open very well. Now you can, but they're squeezing shut because the size of her head is so big and that pressure is so large that it's taking over. So two journalists showed up with a photographer, and they brought two students along, and they were very convicted by this, so they opened up a crowdfunding website, and they were hoping to raise $1,600 to cover this shunt surgery. So the way that we fixed this is we put in a little cerebral shunt that goes in to the space, the subarachnoid space, and drains that fluid back into the venous circulation. And it's a fairly simple procedure for a pediatric neurosurgeon, but they're not very plentiful in a lot of countries, and it's very expensive. So by August of 2013, so this is about a year ago, in 2 months, they had raised more than $60,000 from this crowdfunding website. She had 5 cerebral vascular surgeries. This is her picture of her when she's leaving the hospital. And you can already see that it's improved because her eyes are open. And then December of last year, so not quite a year ago, she had her second aesthetic corrective surgery. And this is how she's looking today. Okay, so totally happens today. Okay, so a lot of times at 201 when we show these pictures, and students think, oh, those are old pictures because they're like black and white images. It looks like something that they would never see happen today. And I want to make sure that you understand. Hydrocephalus is something that we battle in the world right now. And many of you are going to go out into the field, depending upon where you go and what you decide to do, and you may run into situations like this that we don't deal with in our country, but a lot of other countries do. So this is the little story of Runa. Okay, so let's move over. Okay, question. Sorry.
So like at what point can these like increased pressure cause like changes in function?
Oh, so I'm actually surprised that she didn't have more issues clinically. Because if it's left untreated, the mortality rate is really high. So it's almost inevitable that the child won't live. Because you get too much pressure, you start shutting down certain portions of the brain. And then, you put pressure on certain portions of the brain, respirations will stop, they'll go blind. Things basically turn off.
Does that happen when the edema creates something
Mhm.
like that?
So the fluid that's in the ventricles is putting pressure on the brain, and that brain tissue is actually being compromised. And if it has a lot of pressure, the blood's not going to be able to flow into it because the blood isn't pressurized enough to get into the tissue any longer, and so now it becomes ischemic. It's basically like having a stroke. Okay. Sir.
I'm not sure this is a bad question, but how many months in do the hydrocephalus normally occur when
From being born?
yeah.
Well, so it varies. Most oftentimes, at least in Western culture, we'll know at the time of birth because they do a lot of pediatric functional tests just to see, and they measure, one of the things they do is measure the size of the head. So right away, the size of the head is going to be higher than probably normal, like off the chart. And then they kind of watch over the next week, and they see that it's continuing to enlarge. That's usually the first sign. And the child would have no issues at that point, most likely. They might be overly lethargic. They may not be eating well, but they're gaining weight and their head's growing. And so wait a second, something's not right here. So you know early on. You don't get the dramatic abnormalities until a couple of months. But in this country, we usually treat almost immediately. Okay, so let's switch gears. We've covered hydrocephalus, and we've covered cerebral edema. How about herniations of the brain? This is an increase in intracranial pressure. An increase in intracranial pressure. And so in these situations, if you have an increase in intracranial pressure like from cerebral edema or even from hydrocephalus, both of those could cause this, then you would lead to an infarct of the tissue, which is what we were just characterizing. Well, if the pressure in the brain is too high, you don't have blood flow that can get in there because the blood's not pressurized high enough. That compromises oxygenation of those tissues, creates an ischemic episode, and it leads to an infarct. And that would be considered a stroke. Well, the other thing that could happen is you could have herniations of that tissue, where it kind of bulges out into areas that are more void spaces. And the most common ones are shown on this slide. So the subfalcine up at the top, the uncinate down there towards the brainstem, pushing really into the brainstem, and at the very bottom you see what we call a tonsillar herniation, because it's at the back of the throat, really on the brainstem. So any of one of these are a result of an increase in intracranial pressure, however that happens. Could be trauma. Okay? And then the last one that's listed here is considered a herniation of the brain, but it's a special case because there's actually blood, and it's called Aderet Hemorrhage. So the Aderet Hemorrhage that's shown here on the lower left side of the screen, this was named after a physician, and the Aderet Hemorrhage, Henry Aderet was his name, and it causes bleeding in the ventricle and the perimedian parts of the brainstem. So within the brainstem spaces itself is where you would get this Aderet hemorrhage, and it's an active bleed. So it's not a herniation where it's just tissue that's pocketing out. It's actually an active bleeding. We're going to get into hemorrhages here momentarily, but this one tends to be classified within the brain herniation family, even though there's an active bleed that's really considered a hemorrhage, a Aderet hemorrhage. Yes?
Where did you say it causes the bleeding?
So the bleeding actually happens into the portion of the brainstem, to the brainstem. Okay, moving on. It seems today like the slides are more washed out than normal, doesn't it? I'm trying to figure out why. What's that? Oh, because it's in purple? Is that why? But even like the photos, the images seem more washed out than normal. I keep thinking I need to turn off the lights. Maybe I've just been outside too much. Okay. So let's talk about stroke. So we've got hemorrhages, we have herniations, we have cerebral edema, and we have hydrocephalus that we've covered already. Now we're going to talk about cerebral vascular disease, which is a fancy word for a stroke. This is an abnormality due to a blood vessel issue. And there's three things that can cause it. Three stimuli. One would be a thrombotic occlusion. One would be an embolic occlusion. And the third would be a vessel rupture. So a thrombotic occlusion is where you have a vessel that probably has some disease on the inner lining. And that vessel stimulates a clot to form, thrombosis. And that's a thrombotic event where it occludes off, 100% occlusion. An embolism would be where you usually have a vessel, there's disease on the inside and it's slightly narrowed, and there's an upstream lesion that breaks off a piece, and that flows downstream and gets stuck. And that's called an embolus. So that would be an embolic occlusion. The third one would be where the vessel itself is compromised, the integrity of the vessel is compromised, meaning structurally it's not sound, and it actually ruptures. And that creates an active hemorrhage, like the Aderet hemorrhage that we just looked at. And so the vessel rupture leads to hemorrhage, which is direct tissue damage, and then secondarily to ischemic injury. Whereas in the first two, our thrombotic and our embolic events lead to local ischemia. But there's no real damage to the tissue because it's just blood flow is compromised. Does you understand the difference? Yeah, it's going to be, an aneurysm would be one. I'm going to get there here in a couple of slides. So a vessel rupture would be due to an aneurysm. We got a little ways to go before we cover aneurysms. We'll come back to these vessel ruptures. Now, if we look at global cerebral ischemia, this is widespread ischemia. And the widespread ischemia that happens is usually because overall systolic blood flow is compromised. So you've got blood flow or systole that's less than 50 millimeters of mercury. When would that actually take place? When would you see something like that? Shock. Okay, during someone is hemorrhaging out, or they're in shock, or even the heart itself is stopped, or is compromised during a heart attack, okay, where systolic function is not operating appropriately. All of those situations would potentially cause systolic pressure to fall below 50. So the brain cells themselves start to die after 4 to 6 minutes of no blood flow. That's as long as you can last without losing neuronal tissue. Consciousness is usually lost within 10 seconds because it's your body's way of protecting yourself. If blood flow is not going to the brain, the body tries to shut down non-critical functions. Okay, so you lose consciousness and everything goes down to a very, very slow rate. So the clinical outcomes could be mild on the left side of the screen, like, for example, just confusion and a complete recovery, to severe on the right side of the screen, which is large, widespread neuronal death, and the patient may never fully recover. Either they die or they're in a vegetative state because there's too much damage. So that's global ischemia. It can compromise blood flow to the whole organ. Well, what about if the blood flow is only compromised to a local area? So focal ischemia, or local. So in this situation, this is usually due to an arterial occlusion. And it's going to happen probably by one of those methods that I already covered, which is a thrombotic event or an embolic event, where you block off blood flow and you create focal ischemia, that eventually leads to an infarction. Now remember that the blood flow to the brain itself has redundancy built into it, and that was the circle of Willis. Right? So the carotids, the internal carotids come up, and they actually complete an entire crown. So if you have one side that clots off, you actually still can perfuse from the other side. That's how important the brain is. But if one side clots off, there's probably going to be an inability to adequately perfuse, and so you might have some damage, but you may not lose the entire brain. So here, for example, is a focal lesion or an infarction in this particular patient on the right side of the temporal lobe. So thrombosis or embolism, where the blood flow stops because the vessel has disease and the blood clots inside, that would be a thrombus. Or something breaks off upstream, migrates downstream to that narrowed area, and it gets stuck and lodged. And that would be an embolism. Now, we classify these situations when they happen as transient ischemic attacks, TIAs. So transient ischemic attacks, or TIAs, are a temporary loss of blood flow. So on this slide, I'm talking about the slide before, we're talking about when the lesion is large enough and blood flow is compromised permanently, or for a long period of time, until it's fixed. In a transient ischemic attack, you may have temporary loss of blood flow where an embolism gets lodged and then it dislodges and it goes downstream. And you reestablish blood flow after a period of time. And so it's transient, meaning it lasts a short amount of time, but it is an ischemic episode, so TIAs. You can see in this figure, under radiography, here's a normal artery. This is the carotid bifurcation, right? So you have your external and your internal coming up. And you can see in figure 2 how this lumen, or the diameter of this external, is actually narrowed compared to what it's supposed to be. And this narrowing means that it's at risk for either thrombus or embolism to show up in that area. So it is reversible, because what happens is something gets stuck and then it breaks off and it goes downstream, if you will, and it reestablishes blood flow. But the problem is that they're very predictive for stroke, and patients that have TIAs are typically at extremely high risk for having a stroke in the very near future. About a third of all TIA patients later experience a stroke. So that's like a 33% rate. So if a patient is complaining of these sort of mini strokes, is another word that it's referred to as, or a temporary stroke, that doesn't mean like, ooh, I dodged a bullet, let's just keep moving on. That means you should probably investigate further. Why are these happening? Is there something that needs to be done to treat so that we don't lead to a major infarction? So if the blood vessel closes off, and it closes off permanently, and you lead to an infarct, histologically, what are we going to see? That's what's shown on this panel of slides. Hematoxylination stain. You're looking at the upper left. The upper left is a low magnification view so that you can see the demarcated areas of the infarction right here. It almost looks like a water stain, like on a photograph, or someone put their glass of water right here. Okay, so this is the infarct right here. This is all normal tissue over here, normal tissue here, and right down in the middle is our infarction. If you move over to panel C, which is on the upper right, now early on you're getting an infiltration of what cells, do you think? What inflammatory cells show up first? Neutrophils. So those purple dot nuclei are all neutrophils that are invading. It begins at the end of the lesion, or the edge of the lesion, because that's where the vascular supply has remained intact. And you see an infiltration of neutrophils early on. Classic inflammation. If you go to panel D, the lower left, after about 10 days of the infarction, now all of those black dotted cells are what? Macrophages. Very good. So here's an example of how this is cumulative. Because you've already been tested on the first invaders in inflammatory processes are neutrophils. Well, you see that in a stroke as well. Histologically, you see neutrophils show up first, macrophages show up second, that's at about day 10. And then over in panel E, right, this is actually the heel. This is how the brain heals. Not so great. What do you think this is right here? That's scar tissue. That's called gliosis when you refer to neuronal scar. And what cells do you think are responsible for laying down a gliosis? Glial cells. Oh, beautiful. Nicely done. The microglial cells are responsible for this gliosis, or this scarring that takes place after the stroke.
Is there a different input in the PNS?
In the PNS, no, it's still considered a gliosis, and you have macrophages in the periphery that can show up. You don't have the macrophages in the central nervous system. You have the glial or the microglial cells. Okay. All right, so this is what a stroke's going to look like after infarction. Yes.
So if you ask that question, what showed up, it would be macrophages and neutrophils.
So these are macrophages here, but these are microglial cells. So they're microglial type of macrophages. Yes, thank you for clarifying. Okay, so you get neutrophils, you get the microglial versions showing up to try to phagocytose up, and that's what they leave behind, is this scar, this gliosis. Good question. Thank you for the clarification. The neutrophils do show up because you have the vascular supply providing the neutrophils. Okay. If we look at how we treat these on this next slide, and then we're going to take a break, we have basically three options. Our three options, number one isn't on the slide, it's surgery. And surgery is still performed, but it's in a decreasing rate every year. We're opening up the body less and less as medicine advances. So surgery would be that little white space above pharmaceutical. That's where I put surgery. So open surgical approach. So for example, if you had the procedure is called a carotid arthrectomy, where they come in and I don't know if you've seen older patients, maybe like in their 70s, and they have a really amazing scar up their side of their neck. That was probably a endarterectomy that was being done, where they fillet open the neck, expose the vessel, cut out the disease segment, and they sew in a new replacement. Okay? The problem is you have to stop blood flow to sew in the new graft. So there's a risk that you might cause stroke to the patient. So stroke is high post-procedurally for surgical interventions. So now what we do is we treat a lot with pharmaceuticals, a lot of drugs. So we use like Plavix or Persantine, which are antiplatelet therapies, to try to keep the vessel from being sticky and promoting thrombosis. Now, other patients are on aspirin because that's an over-the-counter. That's one of the reasons they do that, is if they think they have a lot of atherosclerotic lesions throughout the body, then they'll add aspirin to their daily regime to try to lower their chances of having a clot that shows up and blocks off that. Now, the more preferred approach these days, when it gets pretty aggressive, is what we call endovascular. So in the endovascular case, what happens is, here's a cross-section between the normal carotid artery, because they come up right here. This is the level of the section at the bifurcation. So you can see the internal and the external side by side. And then here you can see the lining of a compressed vessel that has lumen in that yellow space where it should be wide open like this. So what we can do is we come in, you can see radiographically how that looks on that upper left x-ray. You can see that if you inject a radiopaque dye, that it's still open, but it's narrowed significantly. So right here is the lesion, and that's probably like a 98% or a 99% narrowing. Or it's occluded at 98 or 99%. Okay? And then what we do is we come in with a catheter. Usually loaded on that catheter is a balloon that's deflated, and over the balloon is a stent, a metal stent. You inflate the balloon, you push the lesion out of the way, you deflate the balloon, and you leave behind the stent. And now the endovascular and the drugs are starting to pair up, and we're actually putting in drug-coated stents, or drug-eluting stents. And so what do they elute off? They elute off drugs that prevent them from narrowing, or they make them anticoagulative so that they don't clot off. So these are the two spaces that are kind of starting to collide now and come together. Okay? Questions?
Why does the body not recognize the stent as when it starts to inflammation response?
Well, that's a great question. Why does the body recognize the stent as foreign? Well, it does. Anytime you put anything in the body, it recognizes it as foreign. So if you can use more bio-friendly materials to make your stents, that's one solution. The other one is you coat it with drugs so that whatever that inflammatory process is mitigated, and that's one of the solutions. Some of the drugs that you put on there are anti-inflammatory drugs for that reason. No, this is not surgery. So, well, it's in a cath lab, so it's not considered surgery because it's not a surgeon that actually opens up a major component of the body. So what they'll do is, a lot of times we'll access from the femorals or from the arms, and so you come in with a vascular access in the groin or in one of the arms, depending on where you need to get, and then you feed up the line a wire, and you can see that wire on X-ray on the screen, and you get it into place, and over the wire you feed up catheters with these devices crushed on them. So the only thing that's open is a cut, maybe about an inch or two, like in the groin for the femoral arteries, or somewhere in the arm to access one of the arm vessels. And usually most of these interventionalists will access multiple places. So they usually have a line in both here and here, and then they'll also have an arm prep in case something happens and they need another way to get in, a side door, if you will. And so these are all wire and catheter skills looking at TV monitors. Most hospitals won't do the procedure unless a surgeon is on call in case something goes bad, and then they convert to surgery. But technically this is not surgery. These are called endovascular cases, non-surgical approaches. Okay? In fact, a lot of these people don't have any surgical training. They can cut down into access a vessel and that's it. It's a very controversial field right now. There's turf wars going on between who gets the patient, right? Other questions? All right, let's take a break. We'll come back right here. So, on the break, don't move. We're going to pass out exams